I know we're running a little late. I'm going to introduce our next speaker, really good friend of mine, Alan Block, a podiatrist. He's going to be talking about the impact of amputation on social, economic, and psychological.
Well, I'm using this monitor. I'm not sure if we're going to have... Mike, can you turn it so we can see it?
Like, want me to spin it around?
Good morning.
Yeah, so they can see
So
it. You're
as
on
you can
this
see here, we're
camera,
going to talk
right?
about the psychological impact, economic and social impact of what amputation is really doing. And it's kind of, at first this topic kind of grabbed me, but I think when we kind of explain it, you're going to get on board.
Yeah.
Very simply, and I'm going to run through this, we know very simply that 8% of the U.S. population is diabetic. We have 18 million people who have been diagnosed and about 7-8 million who have not been diagnosed. But let me go and tell you about the 90 million of us who are pre-diabetic and they don't feel they're diabetic. Now at Ohio State where I work, if you are diabetic and you're diagnosed, you have to see a podiatrist. And the interesting part is these people are on metformin and drugs like that, and they don't consider themselves diabetic. And I think the scary truth is nobody's telling them the truth. They need to know if you're taking a medication for a disease, you have that disease state. You are no longer you are diabetic. But again, by 2050, 1 in 3 of us will be diabetic. More frightening than that, the numbers continue to increase, but 11% of the healthcare dollar right now is being spent on diabetic foot care, and you'll see why that's so important in a moment. So about $465 million annually.
Yeah, we'll figure it out.
When you look at it, every 7 seconds someone dies from diabetes, and every 17 seconds someone is diagnosed with diabetes, and every 20 seconds someone has an amputation. The important part about that is this. About 10 years ago, that was every 30 seconds. So we're getting worse, not better. We're living longer, but we're living sicker. If you take a look at these numbers, it's about 4,320 legs and feet are amputated every day. So very, very simply, here's the first thing. First, we make our habits, and our habits make us. And the truth of the matter, a lot of my patients say, I said, why didn't you come in when the toe was dusky? And they say, because, Doc, I know once you start cutting, you don't stop. And the problem with that is, I said, the problem for you that you must understand, you must grasp, is if you're not willing to change your ways, I can't change mine. It's got to start somewhere, and it comes from education. And unfortunately, we have limited times in rooms with patients, and they do need education. They need a podiatrist, they need a cardiologist, they need a vascular surgeon, they need internal medicine, they need a whole host of patients, a whole host of physicians and nurses to treat these patients because they have to understand the seriousness of their disease. And it turns out 85% of lower extremity amputations are preceded by a diabetic foot infection. Matter of fact, the #1 reason a diabetic is in the hospital, 80% of them, is due to the fact that they have an infected foot ulcer. Now, very, very simply, classic case, patient in a nursing home who finally comes in because they want to just amputate the leg, and the family does not want it, and even though this woman is not walking, she doesn't want her leg amputated, and we ended up with the new ability with endovascular procedures of able to shave this down, get blood flow first, and that's the first thing, restore the flow. We call it red gold. If you get me flow, I can do a lot of things I thought I couldn't do before. And we'll talk about tomorrow the fact of patients living with chronic osteomyelitis in their feet, just like they do in any other bone in their body. Because you have to realize once you start to amputate, you also cut down their life expectancy. So very, very simply, you follow this woman over a 9-month course. Now, that's a long time, but you can see she's healing. And she still hasn't healed completely today, but this is her at 9 months.
Because it's 10:30,
Very, very simply, what's happening with the world? You know, we used to sit down to dinner with our families, and it was an extended family. Grandma and Grandpa lived with us. You know, we had the front porch, and I have actually seen the going away of the front porch in the United States of America. We used to know our next door neighbor. Now our porch is in the back, and we have a fence around that back, and most of the time, we don't really even know our neighbors. And that's one of the biggest effects. We no longer communicate with our families, so they don't know what's going on, and we don't know what's going on. But very, very simply, here's where we are. And the sad part about it is, this is where I was 10 years ago until they knocked on my door and they said, we have these endovascular procedures. And back then, they were just happy to take me from the hip to the knee, and now they're doing pedal access and hybrid procedures. And you know what's interesting? You need to tell me that this exists, because the best science out there, the most incredible procedures done, mean nothing if you don't tell me they exist. And that's the important part. That's where it all comes to, because if we don't explain, if we don't educate, not just the physician, but the lay people, just like we did with breast cancer, if we tell them it exists, they'll start to look for it. Because as you saw before, 185,000 patients have an amputation a year, and as Dr. Golzar just said, if a below knee amputation, 5 to 8% of those people die in the hospital within the first 30 days, and, pardon me, if it's above knee, 8 to 12% will die in the first 30 days. And the scary part is, if with above knee amputation, less than 25% of those people ever walk again. And I'm telling you right now, if you've ever walked into a friend's house or a patient's home or anyone else you know, and grandma or their mother is living in the dining room in a hospital bed waiting to die, it's as if they cut off that leg, they bring them into the room, they take them home, and they live inside that room, and they never leave it again. And for the rest of your life, that dining room was grandma's hospital bed. Because we've always done it that way is not acceptable. You cannot live by this motto. Because it's always been done that way doesn't make sense. It doesn't fit, it doesn't make the model, and it doesn't change the lives of the patients we're trying to save.
Can you minimize
And
that
very,
a bit?
very simply, when you look here in 2006, I was driving to give a presentation, and I kept saying BTK because that was the first time in 2006 we saw them going below the knee, opening up the tibial vessels, and saving patients' lives. And patients of mine who had ulcers that I could not heal because they had one vessel run off below the knee, started to heal because they opened up a second and even sometimes a third vessel. And that became the difference. I was driving to Kentucky to give a very similar presentation, and I kept saying BTK because I stopped at Burger King and I bought a Biggie iced tea. When I got to the seminar, I was the guy talking just before lunch, which is one of the worst spots you can have because everybody's hungry and they're getting angry. And I kept saying BTK, thinking everybody in the room knew I was talking below knee amputation. They thought I was saying Burger King. But the truth of the matter, and the joke became that Burger King will get you on the table, but a below-knee endovascular trained physician can get you off that table with your limb intact. And here's the other thing. This is where we're really coming. You know, go back, right? Because the future doesn't look bright. Yes, we're living longer. Matter of fact, the 85 plus is the biggest growing population in the United States right now. But again, they're not living better quality. They're living sicker. And it turns out, very, very simply, sorry about that. If we look at the obese population, we have now given obesity, we've told you it's a disease now. So my patient who comes in, who just can't push the plate away, they now have a disease. They are no longer not taking care of themselves. And it's a hard thing to explain. But very, very simply, this is where we're going, okay? This is what we're looking at. And here's the amazing part when you look at this. You know, when a patient comes in, and I read two articles from cardiology, 2 from vascular surgery, and 2 from interventional radiology. And they all said the same thing. If you open up one vessel below the knee, the patient may keep the leg. If you open up 2, they return more to a normal lifestyle. And if you can open up all 3 vessels below the knee, all 3, this is evidence-based medicine, it turns out that patient can not only restore a normal lifestyle, but they will probably stop using the medical facilities they are at this point. I was sitting with a group of vascular surgeons one day after seeing 5 live cases, and they said to me, Dr. Block, there's not one live case that we would ever enter on. And I said, why not? And they said, because the patient didn't complain of pain, and pain is the #1 reason we enter or treat these patients. And I said, well, that's interesting, because my biggest complaint is my patients are diabetic and they're neuropathic. And the problem with being neuropathic, they can't tell me they have pain. They don't know enough.
Yeah.
They watch their feet decay, and they don't know. And we connected a bridge at that point because what I was saying, what they say, met halfway.
Can you try that?
So when I do an ABI on a patient, and I'm explaining this to my patient, I don't go through the waveforms. I don't tell them monophasic and triphasic. I simply go, this is your heartbeat in your leg. And when that's flat, you're either losing your leg or your life. And so the connection must be, for any medical professional, is this. We as medical professionals can no longer afford to be deaf to a patient as mute. We can't. We must go forward, and that's how we change what we're doing. That's how we change the psychology of what we're doing with these patients. Because the key here is surveillance. And these patients think one and done. They think once they have a bypass or they have some kind of endovascular procedure to their legs, they think they're
Now,
cured,
which
and they're
camera am I
not.
gonna be
This is an
being
organic
seen on?
process, and it's important to us to explain to
This up
them
here?
what they're really
Okay.
going through. And it turns out
Just
that
like this is
unfortunately
fine.
this continues to reign,
If they
what
can
Craig
see
Walker
it.
said. For some reason, it's considered conservative care to chop someone's leg off and aggressive treatment to even do an angiogram. And unfortunately, I look at it this way. There's
is
the
the camera
difference,
that they're
if I get a
looking at,
traffic
like-
ticket, I am not allowed to be negligent under the law. I am not allowed to be ignorant. I have to know it. And I think the same thing in medicine. We can no longer afford to say we're ignorant to it. It's negligence, and it's medical malpractice if you're not treating these patients the way it should be done.
Hey
So
guys,
it turns
plug
out,
in.
again,
Let's
less than
go.
20% get an
How long will it
angiogram,
take to boot?
and only 50% get an ABI, and I don't know why that's running, excuse me, so quickly. But it's not conservative treatment to amputate. We know what happens with these patients in 5 years. How do we treat the disease? Well, you know what? This is our children, and this is the Michelin boy. And maybe we just arrest the
Like, we
people who
need to
run
have it
McDonald's and
showing at
Burger
that
King.
camera
Maybe
right
that's what
there.
we do. We blame the purveyors of you know what? They've been
I can
around for
see
50
this screen.
years.
Is there any way
We
you
have
can
more
turn
single-family homes, we have more computers, and we exercise less, and that's what our kids do. And that's really
Okay,
where
so
we're
why don't you
heading.
turn around so they can
So
see
how do you
that
treat
screen and I can
society?
see
It's
that
real
one.
simple. You invent what's going to go on. You invent the technology, you change, and to address the pathology, but you must change the psychology of the treating physicians.
Pull it back towards you.
You must change the
Towards you.
psychology of
Oh.
the physician who sees this patient at entry level.
Okay.
And you
Can you
disseminate
mag
the
up on that?
information like we did very simply to patients
Mag-
who are
and mag
suffering
as
from
much as
breast
you
cancer.
can.
Because this is the United States.
Okay,
This is what
that's good.
we're getting larger, we're getting bigger. You know, this is global warming essentially. But the bottom line, excuse me, sorry about that, is this: only 31% of wounds heal. That's it. 85% of the amputations I told you earlier are preceded by a foot ulcer. 80% of the hospital admissions are for diabetics with infected feet. If the wound's not half the
We're at,
size in 4 weeks, you
9
must
o'clock.
change what we're doing. And the bottom line is this: the take home is this. All
Can you
these
mag it
things
up a
we're
little
doing
bit
for
more?
feet, up to $48,000 a year to treat these diabetic foot. What happens if we started by restoring the
I have 2
flow?
pictures there.
If we started doing it. And you know the one reason maybe we don't restore the flow is because we don't know we can do it first. But I
Can you mag it up
guarantee
just
you,
a little
doing
bit more
nothing
and
else,
focus on
more than
that?
31% of those patients would heal.
Mag it up.
And I thank you very much.
Bag up. Okay, that's what they're going to see, right?
Thank you so much, Alan.
Now you can switch
next
back
we
over
have
to,
Dr. Harkless, who's
can you
going to be
switch back
talking
over
about
here so I can show
distinguishing
'em what we
ischemic
did?
and from non-ischemic wounds, which is a very, very
Now,
important topic.
you can see
And because if you don't know what you're treating, then you're not going to be able to
then
treat
what
it
we did here,
correctly.
right? So we can see all this, right? You're able to see all this? Paul? Are they able to see these videos?
The right button? The green in the middle? Oh, that one, that's it, okay, good.
Okay. Paul, come here for a minute.
This is how I think about ischemia
What can they see?
in 2014,
This and this,
but
or
this is
just
a patient
this?
that I
They're going to see this.
performed an elective bunion on in
Okay, great.
1980. He had a ulcer about the
That's
size of
fine, I
his
just wanna know
toe,
which one they can
about
see.
a quarter at the medial aspect
you're
of his
set, right?
bunion, and I
Mike?
treated it for about two and a
Mike,
half
your son?
months, and it reduced in size. He had a
Okay,
pulse
we're
as
ready
strong
then.
as my pulse.
Yeah, we're all
I sent him to vascular. We didn't have vascular at the time, but they had general surgeons who did vascular, and they
Right here.
did the non-invasive testing. He told me he would heal. But this is 4 days post-op, and that's when I was at the University of Texas, and I thought they were going to send me to Huntsville, which is like San Quentin. I live in California now, because I messed up, and I read
that?
everything I could read, and I was scared, and I
Yeah,
realized
the one that I'm looking at right now,
all these things were going on in this
keeps
foot
on
at that
going, it's
time, but
good.
I didn't think about it. So I have a slide
that?
at the end called heterogeneity. So I want to
I
leave
can
you
see
with
it,
that
yeah.
slide at the end, and we'll talk a little bit about how I look at ischemia.
I don't care if I
But
can
just
see
because
me.
the patient has a pulse does not mean that they have great flow.
Is that what they're seeing?
Because the autonomic nervous system controls the
They got my
ability of the
head cut
vessel to dilate, you can have functional microvascular disease as well as occlusive, and oftentimes we overlook that. And
So this is the
so,
camera I'm looking at, right?
you see what you look for and you recognize what you know.
we need the room
So my
light?
goals are what? To determine the risk spectrum of
Would this
vascular
help?
disease,
That
and
helps, right?
what evidence is there to support that by your history and physical.
We'll try
I
to
would,
work
I
with
would
this.
surmise that
I may
most
have
of
to
us don't
darken
park
it
at the
when
bed.
screen
We
goes
get in a
on.
hurry. When I've missed
Can you
something, it's
flip
when I
over
didn't
to
park
the
and
other
ask the right
screen with this
questions.
being light up
If
and
I
just make sure
search
that,
myself and ask the questions, and
with the light
Thomas
on, it
Campbell
works
said, coming
pretty good.
events
Okay, it
cast their
does.
shadows
Good.
before. There's always a shadow before the event. So I have 14 questions I ask every patient to allow me to decide, is it ischemic or not? Is it a combination of neuroischemic? And that's not part of the talk, but some ulcers are neuroischemic. So my 14 questions include, I think I have a slide out of order here. Let's see, where am I? Yeah. So the 14 questions include macrovascular disease, microvascular disease, functional microvascular disease, and the metabolic syndrome. So 2 questions, we all ask these questions. Do you have a history of coronary artery disease, a stroke, and is there any CLI, or history of intermittent claudication? That may not be present in patients with diabetes because of the neuropathy. As we already know, they may
My
not
mic is up
necessarily
way
feel
high
that,
now.
but they may
I got a
have
lot of reverberation.
claudications that's masked by the fact that they have the neuropathy.
Yeah.
We ask these questions, retinopathy, neuropathy, nephropathy by history. They can't tell me whether they have that or not. If that's the case, I'll call the primary care physician up to find out exactly how
normally
they
have
had their
something in
eye
my
exam
ear?
and the minimum standards for
Well, I can
appropriate
usually
care
hear
in
them,
that
yes,
regard.
very well.
Microvascular dysfunction, gastroparesis, and sexual dysfunction. Again, oftentimes we may not ask this question, but how many times will the patient have sexual dysfunction if they on Cialis and Viagra? They already have that, the die is already cast. And these particular patients do not heal as well, and they'll fall into the ischemic category just from a functional perspective. And then we have the metabolic syndrome, impaired glucose tolerance. That's the pre-diabetes that Dr. Block was alluding to. Insulin resistance, dyslipidemia, obesity, hypertension, and smoking. And then family history. This is the genetic predisposition. So if you can get with the genomic aspect of it, I have everybody in my family on my father's side have diabetes. I'm sure I probably have that gene. I'm in pretty good shape and I eat healthy and exercise. But I believe that the likelihood for me getting diabetes is high. And I'm about a year and a half of getting my Social Security check, and my wife says it's time to retire. Now, if I retire, it'd be like the evolution that Dr. Block was talking about. I'll probably get the diabetes because of the genetic predisposition. Now, the interesting thing is that this is a natural history. It's a continuum of the disease. And so when a patient comes in with a wound that's not healing, it didn't start the day they walked in, because they've had diabetes, all those other contributing factors for many, many years. And so that's where this process, while we're a doctor and not just a technician, where we have to understand all that and put all those particular multifactorial points together to help us understand. And clearly, this is just an overlap slide of Venn diagram demonstrating the interactions of coronary disease, cerebral vascular, and PAD. So the question is, what are the vascular foot signs of diabetes? And these are listed. You probably know these. These are all listed in most vascular textbooks in terms of the signs and symptoms of vascular disease. But one cannot see what you do not look for. So it's important that you know what they are. And I think my response to orders relate to a list. Arturo Guande wrote the checklist manifesto. So if you really want to get good at something, you have to make a list and you have to check it to be sure, just like the pilot did when you get on the airplane. He's providing his checklist on a consistent basis. So for one mistake for not knowing, 10 is made for not looking. So I will challenge you to say that, do you palpate the pulse from the abdominal aorta to the dorsalis pedis on every patient you see? I believe that I'm as good as the non-invasive test because I've been doing that for almost 38, 40 years. So I can tell you if there's a blockage because I felt it. Now the test will confirm what I did clinically, and then if you listen to it, that will also help also. So one cannot hear what he doesn't listen for, and that's where the technology and all the different sophisticated modalities come in. So that's important. So the question here, how do you differentiate ischemic versus non-ischemic wounds? This is a classic ischemic ulcer. There's no granulation tissue. You tend to have yellow, gray, non-viable fibrofatty connective tissue, depending on the area where the foot is located. And if you are in the top part of the foot, it's really a lot of tendons and fibrous connective tissue also, and if it's not healing, that tissue tends to be a lot more avascular and will turn yellow or brown looking. You will have bleeding around the margins of the wound, not necessarily in the center, and you will have all the signs and symptoms of vascular disease, which we've demonstrated in a previous slide. So this again is that ischemic or non-ischemic. Well, this is the same wound, that's an ischemic wound. And this is a classic neuropathic ulcer. You'll have a callus. If you debride the callus, you'll have a nice center granulation tissue, and you can see surrounding hyperkeratotic tissue around the margins. And this is just generally a pressure point. So it's important to establish the etiology of why the wound develops in the first place. So is it structural deformity or abnormal biomechanical function that predisposes to that along with limited joint mobility? Or was there some type of minor trauma? It was demonstrated in the causal pathways to amputation that minor trauma, neuropathy was implicated in about 78% of them, but minor trauma was also very, very common. And that's because pain is the gift that nobody wants, and Aristotle said we cannot learn without pain, and patients with diabetes tend to have neuropathy. There are two types of ischemia, relative and absolute, meaning that the relative ischemia means that you have some flow, but it's not enough perfusion to heal. Absolute is when you have no flow and it really turns black and you just have frank gangrene. I think it's important to think about the mechanisms of ischemia. You can have pressure ischemia. So if you think about the foot, you have a first ray and fifth ray. Anything that puts pressure there with enough pressure over time, you can cause a bleeding and a blister, and you can have just necrosis just from that alone. You can also have ischemia due to vascular disease, where you can have like a puncture wound or some other minor trauma, and it just doesn't heal. and you can also have ischemia secondary to infection. So when I see something, I'm thinking about all these different mechanisms and document that in my chart so I can actually follow that over time to be sure am I correct. So this is, again, a pressure ischemia from a bunion here. This is just enough pressure there over time, similar to a decubitus ulcer on the back of the heel because they went to the CCU. Nobody paid attention. They was in there for a week, and next thing you know, they had a nice little wound that developed on the back of the heel. So this is an example of a similar wound that had an ulcer on the side of the toe. However, it got infected. So this is an example of, because of the infection clots off the blood vessel in the toe, and so the toe turns black. Now you can say that is this primary ischemia or is this ischemia secondary to infection? So you can go all crazy worrying about that, but you have to decide which one it is and why, because that will guide the therapy and how you plan to manage that particular problem. And so this is a wound here kind of on the medial side of the foot here, but this is where a combination of neuroischemic, you see some granulation tissue there, but also I see some yellow fibrous tissue. So you're probably getting some flow, but there's some ischemia also there. And so this begs the question of where's the lesion? Now, if you know your vascular anatomy, there's something in the distribution of the vascular anatomy to explain why they have the ulcer. So I'll write that in my chart without getting a test. Because if it's medial, it's probably medial plantar, the posterior tibial, or may come off at the trifurcation there. But I think that if you look at that, you'll know. This is a very interesting patient that had ischemia with secondary infection. She had a nail problem. I was on call that night. The resident called. It was a nail problem. She said, well, I think I need to take the toenail off. And I said, fine. And so when I rounded the next morning about 6:30, this is how it had progressed. The patient did not have this the night before, like about 10:30 when I got called. But you also see the redness and et cetera. Now that all came from this problem. So she's developed an inflammatory response just from this ischemia. She did not have that the night before and did not have any redness around the toe. She was just concerned that the nail was a problem in one little small corner there. But that's how this can progress. But you can also notice how parallel this particular foot is as well. So I think it's important to prioritize infection versus ischemia. These slides are all just indicative of just strictly ischemia, where you have a black area that's non-healing. I don't see anything that looks like it's infected. So this is an example of where you can deal with the blood flow and not necessarily worry about infection and doing an incision and drainage. And we talked about functional microvascular disease. This is a patient that actually had that. If the foot looks paler, that tends to denote to me that it's a functional problem. And I also asked the question about do they actually have sexual dysfunction. So this is my slide again, how I look at that. Again, see what you look for, recognize what you know. But again, microvascular, functional microvascular, metabolic syndrome, obesity. Obesity is a cumulative effect. All the changes that are going on at the cellular level in diabetes, there are 4 pathways that lead to these vascular complications: the polyol pathway, advanced glycation endpoints, abnormal protein kinase C, the hexamosamine pathway, and then there's a polyribose whatever. But Michael Brownlee is the guy that knows the most about that from Einstein in New York. But I think about what's going on at the cellular level because it's inflammation, and I explain that to the patient. And I found that if I can explain to them in an anecdote similar to what Dr. Block was talking about, I found that the patients tend to understand and they tend to
you hear us?
decide that they want to do better in terms of how they take care of themselves. And so I think that's a very, very important point. The other issue is the structure of the foot. Peter Cavanaugh had an important article in his book, The Foot and Diabetes, called Linking the
Can you
Risk
guys hear
Factors.
Dr. Davis?
And he said the structure of the foot, which is deformity, footwear, lifestyle, which is psychosocial, and activity level, have to be linked. And the question is, why do they have it, and how may recurrence be prevented? And I think that you have to look at those particular aspects and say, is it one of those or is it multifactorial? And when you start getting recurrence as it relates to the foot, the psychosocial aspect is important. That's who you are, whose you are, why you are, where you're going, and where you came from, an activity level. And again, yeah. No problem. No problem. Okay, no problem. I had one more slide. Can I see my one more last slide? I just want to put it up. I'm not going to talk about it. They won't let me go forward? Is that the end?
Yeah, I think
Are you
we'll
guys
go ahead and
almost
move
ready
over
to
to our
introduce
live
Dr.
case.
Davis?
Thank you very much.
You comfortable there?
I'm going to also ask Dr. McNamara to join us on the panel for our live case. So our live case is coming to us from Detroit, Michigan, St. John's Hospital, Dr. Tom Davis. He's in his world-renowned interventional cardiologist, good friend of mine, well-known to all of us here. Should be going live here pretty soon.
All right, can you hear Dr. Day?
There we
Are you
are.
ready for him?
Tom, can you hear us?
We're doing great. We're just getting started here.
We can see you, Tom. We're just trying to see if we can turn up the
Can
audio.
you guys hear me?
Yes, we can hear you. How are you doing, Tom? It's Jaafer Golzar.
They can hear me. I can't hear them. How are you doing? I'm doing great. I can't hear you. Maybe that might be better if you guys are muted, though.
Let me know.
Is there any way, Paul, you can get them over so I can hear them?
Can you hear us now, Tom?
Oh, okay.
The pleasures of doing a live case. Can you hear us now? I'm going to go ahead and introduce our panel, if you can hear us. We have here Dr. Tom McNamara, Dr. Amir Matarjame, Dr. Miguel Montero Baker, Dr. Zakir, Dr. Harkless, and Dr. Alan Block. We're all here patiently waiting and anticipating a great case coming from you. I don't think that's the live feed that we want.
Okay. Can they hear me? Do you have the camera even on us?
Yeah, we can hear you. We just see the ceiling is pretty much all we're seeing right now. And I think there's a fly on the ceiling there. All right, we can see you now.
Okay, we'll get talking. Hopefully you guys can hear me. Well, good morning from Detroit here over there in Chicago. We got hopefully an interesting case for you here. It's a gentleman who actually has a renal transplant. He had about a year ago an ulcer on his left leg and on the toe, and he had intervention on that leg and about a year ago, and that had did well and he healed up. Now he's had a ulcer on his toe on the right leg now, and he's had this for about 3 months, hasn't healed. His ABI was non-occlusive, and his TBIs were 0.3 on this side. So he has no rest pain, but he's had this. So I'm going to show you our initial pictures here. Let me just go back here. Are they able to see these? So here's the initial angiogram coming down here. You can see sort of the SFA is totally occluded, a little bit of calcification there, but you really don't see much coming down. We did some digital subtractions here. You can see the profunda, but it's a little hypoplastic as it gets out here, which is really probably why he's not getting great collaterals. But you can see coming down here, he's totally occluded. And then when we give flush right here at the level of the popliteal, we're really still not seeing much. We see just a faint anterior tibula in here. I'm not sure if you can see that, but I can barely see it. So anyways, and he's totally occluded here, and you can see this. We get a little bit better picture when we do a direct injection there. So anyways, what we planned on doing here is we're going to cross with the ocelot, and that way we can get down there and see where we're going to, and hopefully get down to the popliteal, take some injections, get a little bit better idea what we're going to be dealing with. Like I said, it looks like there's a faint anterior tibial down there. So what we got set up right now is in there, in the body, we have the ocelot. We got a sheath coming over, 7 French sheath crossed over. It's just in the origin, the SFA. And we have an ocelot catheter, which we're hopefully going to be able to show you as we go down there. What it has, it's an OCT, light-generated distal tip on it, and with like a auger tip, so it'll actually go through the total occlusions, hopefully, and get down there. And we're going to try to maintain within the true lumen or within the lumen by this, so we can hopefully see this better. So I'm going to see we're going to turn it on. And can they get over here on this bottom screen now, Paul? Okay, so this is the ocelot catheter here. What it is you can see the distal tip is pointed sort of towards medially. It's got a flexible, it's got a flexion tip on it, and so the way we can direct this thing is that our middle marker is always away from the tip. So what we're going to try to do is put that middle marker on layered structures as we see them. So we're going to go ahead, we're going to stay off fluoro here. And we're going to go down. Can you tilt that screen just a little bit so I can see it? If you want to, I don't know if there's any questions as we're going. Unfortunately, I think we can't hear you guys at the time, but if anyone has any comments, Paul, you can switch back to them.
Tom, can you hear me?
Can you hear us, Tom? I think they're working on the audio right now. It looks like it's from their side. So it looks like it's a long SFA, chronic total occlusion. He's trying to get through it with OCT-guided technology, which is pretty nice because it allows you to visualize, and the key point with that is that it keeps you in the lumen and without going subintimal, and that's sort of the point of it. You guys have any comments?
It doesn't look like there's a clear reconstitution, so it's, I guess he's kind of just going to go down there and see what really happens.
Actually, it looks like it maybe came back there right in the mid-SFA, and then it occluded again distally.
Again,
I think that's subsequent
runoff. I think
angiogram.
he mentioned maybe a hint of an AT.
Mm-hmm.
I think one of the advantages
Okay,
that
so I think you guys can
add,
hear me now. We have to go back and forth, unfortunately. Something's wrong with the audio here. But what we're trying to do is, you can see on the screen here, we sort of see layered structures at 3 o'clock. That is where that's where we're going to try to get that middle marker over to. Got here.
So it sounds like
I'm just
our
rotating
AV
it
team
over
is telling
there.
us you can hear us now, Tom?
And the layered structures now and I don't have fluoro on, so we're basically just going by OCT guided.
Can you hear us
So
now,
we'll,
Tom?
keep on going down here. Stop right there. Keep going. So we're going to keep on going down here. Again, I'm trying to keep up the catheter so we can see layered structures. Again, you can see, you had the chance to see a little bit of layered structures. We're going to see exactly where we're at now. You can see we've actually made pretty good progress so far. We're down into the mid-SFA, so keep on going. You can see a little bit of layered structures down at 6 o'clock. So we're going to try to point this down there a little bit, get it rotated around. And keep going.
So
there's
the
a little
nice
bit of
thing
an
is you
opening
can
here, a
actually
little bit.
do
So
this
now we
without
see some
any
layered
fluoroscopy.
Again, there's not really, you can see that we're in 4 sort of fibrous plaque. Stop there. Now I'm going to give a little bit of a flush here just so you can see what we got, or maybe give a little bit better idea here. So you can see layered structure sort of at up towards 10 o'clock. So we're going to rotate this device up there. Okay, keep on going. Keep on advancing.
So what he's doing, he's rotating the middle marker to keep it away from the
Plaque here, you
adventitia.
can see, keep going. And we're going to keep going here. Again, fibrous plaque. We don't see any good layers, so we're just getting we're in the middle of the lesion here, really. So, and again, we're doing this all by OCT. We're not doing anything else by fluoroscopy. Why don't you stop there now? So we see layered structures down at 6 o'clock. I'm going to see approximately how far we've gotten down here. So you can see we're actually down into Hunter's Canal right now. So we're going to keep on going. We're going to keep on seeing it. I'm still rotating the device to try to get this catheter. So why don't you stop there? Every now and then I stop just to get the catheter lined up with the layered structures are. Again, we sort of see layered structures. You don't see it very well there on the camera, but if they're about 12 o'clock. Okay, keep going.
Does any of
just
the
keep
panel
on
use the
nudging our way
Ocelot
down
technology?
And why don't you stop there?
You want fluoro and OCT at the same time right now?
And then I think, and what you can see here now you see this is what we call a starburst. You can see the vessel now. We're actually into an open vessel. So I think we got to be pretty well down to it. Now we're going to go down
Yeah, that looks good.
and we're going to see if our wire goes down there.
So what Tom was
I'm
talking
just
about is as
advancing
soon as
over
you get
for a wire.
into the
You can see
vessel,
it
you
actually
see a
going down there now.
starburst.
So we do have something down there. Looks like it's an open vessel someplace. So we're going to keep on coming down here. I'm going to back this up so you can see. Okay, keep on coming down. Just follow the wire now. And we'll follow the OCT as it goes down there because I know it's an open vessel, but we may have another occlusion down here. So why don't you stop there? And what we can do is, I'm going to see if that wire will go down. It's just an 014 wire in the middle. So it is going down into something. I may be going down into another lesion there, or it looks like it may be a genicular branch, possibly. So what I'm going to do is I'm going to get some dye now in here. And we're going to take a little bit of a picture. So that it has a flush port to it that you can actually make an injection into. And we'll see if this does it. Hopefully it works for us. We're going to fluoro again. We're going to see if we got anything down there at all. Okay, and so we do have a vessel down here now. And so what I'm going to do now is we're going to try to take a angiogram through here. Let's get some of this mess off here so we can see a better picture. And we'll see what we got. Now it looks like we do have a little bit of an anterior tibial here coming down now, which is good. We'll take some more pictures all the way down here, see what it looks like. And again, decent tibial branch down there. We're going to come all the way down to the foot here. And we'll do one more injection through that port. So not bad, a little disease down there distally, and not that bad at all. So what we'll do is we'll try to get another wire down there. Do you want to give them back? Want to give them back to the mic? I know Jaafer's probably dying to talk right now. You can switch it back to them. They can make some comments or have any questions, and maybe ask them what I'm going to ask you guys what you want to do at this point in time.
Well, no, I was saying before, this Miguel Montero Baker, one of the, I think, main advantages that you're getting out of a device like this one is that you actually have imaging to know that you're intraluminal throughout your procedure. That puts you at a comfort zone because it opens the variety of tools you could then potentially utilize. As you go subintimal or another sort of more aggressive recanalization techniques, then you limit yourself because most atherectomy devices, at least per their IFU, will limit you not to utilize that. Not that I would think that this is a case in where you want to do just atherectomy and balloon alone because of the complexity of the lesion, but certainly it could be a tool you would use to debulk, to create space, and then to optimize size for an implantation of whatever implant you want to have at the end, which ultimately what you're trying to get is adequate luminal gain and a nice deployment, which across the board or anything from PTFE to interwoven to drug-eluting, everything's going to work better if you could get an adequate size acutely and no acute elastic recoil. Now, my specific concern about this lesion is you have one single run of vessel down to the foot, and it's a complex multi-level lesion. So in the back of my mind, I would be very weary about potential embolization during this procedure, because then you're going to be chasing small clot or debris down the only single vessel this patient has. So I would have a low threshold to use protection devices, sort of like a filter, for example, in a case like this one. But I know a lot of people don't like doing that. But I don't know I don't know if Tom's listening, if you have that, and if not, at least some people here in the panel that would comment on how they would protect that anterior tibial artery.
Okay, I guess I get back and get to answer that, Miguel. I agree with you. Single vessel runoff here is a concern. So I think what our plan is here is to use actually pathway. I have pretty good luck with this in terms of we have lesions like this with we now have a little bit of an opening here. Actually, the ocelot causes that a little bit, and I think with the aspiration aspects of this, I don't really see that much distal embolization coming forward. Can I get another regalia, please? This one's a little bit. So I'm not one that uses a lot of distal protection because I think that distal protections also can be a little bit of a problem too as well as you go down, with different types of problems with the filter causing problems down there, because you got to have a diseased popliteal here as well too with that. So But we're gonna do pathway here. I don't know if everyone has ideas about that. Having a hard time getting through this area there. We're going to get a different wire. This is a little bit buggered here. I'm going to take a little bit of an injection through this port. So why don't you give them the mic back, and everyone else can talk for a second while I get this, and except you can keep the mic off of Amir, because I'm not sure if he likes what I'm doing.
Another approach to reduce distal embolization that I often use is to take a clearway catheter and administer a ReaPro. And it's amazing, that you're able to see, often straight line flow down the artery just by doing that, just by, administering, a 2B3 inhibitor. And that I found to reduce, embolization significantly in cases where, often I don't, need to use a filter. And, it's you have a long CTO, you administer it through a clearway catheter, and all of a sudden you see straight line flow, you see a straight channel. Any panel of using clearway and using 2B3A?
Tom, this is Amir. First of all, good morning, and wonderful job so far. But there are a couple comments I'd like to make, and one is that you have a single vessel runoff. It really not bad idea to put a distal protection in, especially that you probably don't have to work all the way down to the anterior tibial, so you can park it right at the origin of anterior tibial artery, number one. Number two, we have this disadvantage of not seeing a good angio that what's going on throughout the superficial femoral artery. So it's definitely, if you want to do a atherectomy, I think the pathway is the right one to do, because you may have some clot burden too. So, but debulking probably in a long artery like this is a pretty good idea.
Good morning, Tom. Tom McNamara speaking. We really, at least from my standpoint, couldn't see much of the detail couldn't see any for me, of the detail that you were looking at. And I think the novel part of your procedure is the use of the ocelot. Could you review what you were seeing and looking for, and how that influenced how you manipulated the ocelot?
Sure, Tom. Unfortunately, hi guys. What we're looking at on the for the ocelot is, as I said, what you're trying to do is obviously stay away from the wall. As you're going down through the vessel, you're causing eccentricity when you're crossing, and so what the benefit of this catheter is that you can get directionality. So what I'm really looking at is layered structures. You can see media and adventitia very nicely. So when the catheter gets up, when you see that media stripe there, what we call layered structures, what we do is we put the middle marker over that layered structure. And then when we're over that, we know the catheter tip is pointed away from it. So it's going to be going away from the media, so we're not going to be going into the vessel wall. And then when we get done there, I don't know if you saw that very well, when I actually injected, you saw this sort of bright, we call starburst. That's where the saline's hitting, the blood is hitting the distal tip there, and you'll see the starburst effect, so you know you're all the way through the vessel, and you can see that there. So it's a nice way, and the nice thing, advantage for me is that we were able to go through that entire vessel really with minimal use of fluoroscopy. And here's a picture of it, because I heard Amir saying he hadn't seen what the picture looks like afterwards. I know you saw before, and this is what we have afterwards. We saw from the popliteal on down from where we are. So we actually have a channel here. And so I like everyone's idea that they're agreeing with me with pathway, at least at this point in time. What I'm going to try to do, though, is that I'm not going to put a filter down here. I know everyone will criticize me for this, especially if I have an embolization. But we're going to try to do this without this. I know in Zeller's data that he did this. He had an angiographic core lab, and when he did all his stuff for this device, and it wasn't even as good as the device at the time, he really did not have, he only had 2 distal embolizations out of 172, I think it was, so somewhere were around there. So even though I'm probably not quite as good as he is, but I think that it's technique driven. I think if you go slow and you aspirate and you watch what you're doing, I think you limit your distal embolization. So we're going to be bold and brave and do it without that. And I know Amir is going to call me nuts here, but that's okay. So you guys can go back. So what I did was I just put the pathway jet wire down there, and we're going to put the pathway device over here. And we'll see, actually, Amir, we'll bet a scotch on whether or not I have distal embolization. How's that?
Good. Tom, what size catheter are you using?
2.4 by 3.4. We're using a little bit larger. Obviously, it's an SFA, and you know sometimes it depends upon how big the vessel is, deciding what to do. Sometimes I'll use a bigger device or a smaller device just because I notice they get a little bit of a pain when we go up to the 3.4 millimeter blades. So we're just going in there with this device up right there.
Are you going first with the blade down?
My eyesight's not so great anymore, so I have to make things really mag. Go ahead, push in there. Okay, so we're getting the device down here, and what we'll do is we'll start about right here because it was open up to about this point. And what we're going to do is we put this device in the loop, and so as we put that in the loop, the wires distally, that loop should grow as we go down here. So we're going to try to get the hands, once you get your hands up like this, there you go, so we're not radiating you all the way through there. I'm going to unmag it, or I'm going to keep it magged up so you can actually see what this looks like as it goes on. So as it spins clockwise, you can see those blades. We're going to go really slow here, and we opened up so you can see how it wobbles. Keep on going. And the nice thing about it is you get a tactile, or you get the auditory feedback here. We're on the small blades. We're going slow.
Tom, could you switch it over to fluoro shot? We're on the camera shot right now.
You can see now it's engaged, so it starts to come down a little bit on the RPM. So you want to go very slow here. And as with any of these devices, you got to go slow. So we're coming through here, nice and easy. We got a good aspiration coming through here.
Hey, Tom, we'd love to see you, but right now, I think it would be nice to see fluoroscopy, if we may.
We can't. We're on the camera shot. If you could switch over to the fluoro shot. There we go. That's better. Now we can see fluoro. So as you can tell, his technique is moving very slow. He's going in with the blades down first to create a pilot channel. Moving very, very slow, allowing the drill to, which spins about 70,000 RPMs, to drill through that, and then at the same time, mechanical aspiration of the debris. We lost audio. Looks like we lost audio.
Down to the popliteal area with this, because there was disease down into there, and we're through there. Keep going. We got good aspiration. That's the key to this device, is watching, making sure the aspiration. So you can hear it coming down now. We're going to stop, pull back a little bit, let the RPMs kick up, and keep on going back down. Keep on going. So we're going to keep on pushing through here. Nice and soft, nice and soft. Okay, so I think that's the key to limit your distal embolization. By coming nice and slow and let the device work and let the aspiration work. So we're almost down to the popliteal, and I think, going back to my previous picture, I think this is about where we had another lesion. So I'm just going to go down with these blades down right here. You can see it's engaging it, so you can hear the RPMs drop again. We're just going to be a little bit slow through here again. Keep going now. Keep going. We still got very good aspiration here. I think that's about as far as we want to go. So what I'm going to do is we're going to Rex this back. You're going to push that button there on the Rex. And I'm going to take this back to the proximal portion there. And
Tom, do you have
what
calcification
this is doing is the
visible in
blades are
that
not turning,
popliteal
it's just
artery?
aspirating. And so that way, you don't have the, you're still aspirating debris as it comes back through here. So what we're going to do is, up now, so we're going to come back down with the blades up, and we're going to come, so we just hit the button on this device. You see it's got 2 buttons for blades up, blades down. And we're going to start going with blades. Just keep on pushing through there. Stop, go slow now. Okay, keep on going slow. They just, you heard them just talk about how your nice technique was. Now you tried to blow it on them, huh? It's always fun. This all those are dry, huh? So we're going to go nice and slow here again. We're going to listen to the auditory tactile coming back. So we're going to come nice and slow. We're going to come back a little bit. And just go forward again. Just to let the device catch up. So it's coming down there again. As you can see, we're making really good progress here. Sometimes it's tedious to go slow, and you can see we got some opening there. So we're going to keep on coming down here. It goes about that speed, okay? If you hear, so the key here is really the auditory aspect. You know, the one thing is I don't usually actually go on fluoroscopy when I'm having this thing. So you want to come back again. If you hit something that's red, go back, pull back. You see, you hear that auditory drop there. So go forward now. So that's a tight lesion there. We're going to go slow again. You can see the blades spinning there again. And this is what it does, is it's a counterclockwise spin. So this is what causes the blades to go out into bigger 3.4 lumens. So keep on going nice and slow. So we're making good progress here. Keep going. A little bit faster now. So we're doing slow progress here. You can see as it's in a bigger vessel, it sort of starts wobbling there, so to speak. So you're going to stop, let it back up a little bit, take a little tension out, go forward again. Okay, so you hear the auditory click that you're getting there, so you want to back off again. Keep going forward now again. Not too much, let it cut, see, let it cut, come back a little bit. Okay, go forward again.
So that's where you get distal embolization, is when you push against resistance, especially with the blades
again, I think
open.
the key to limiting your distal embolization is really technique driven. Come back here again. So I'll tell you what, if you want to switch the mics back to the panel just to let them talk a little bit.
So that's sort of, if you didn't hear me before, that's sort of where you get distal embolization, is where you push against resistance. And you can see his technique moving very slow, pecking at the artery as he comes back and forth, especially with the blades open, because you're really going to get a lot of debris. And if you're pushing against resistance and you push too fast, the aspiration mechanism is not going to have enough time and enough force to actually aspirate that debris back. So technique is very important here.
Our aspiration very carefully here too as well. And that's the other key, I think, is you always really have someone watching that aspiration, making sure that you're getting flush back there. Because if this gets clogged up a little bit, obviously then everything you're cutting is going down distally. So it aspirates about 30 cc's a minute. So we got a nice aspiration flush coming back here. So we're almost down to the popliteal area here. Now it's coming down, bogging down here, so you can hear that limiting there. So we're going to come back a little bit. We're going to go down nice and slow. Again, how are we doing on the aspiration? So we're still doing good on the aspiration. So we're coming down. You can hear the auditory coming down again, just pecking at it as we come. I don't think we're going to go down too much farther. We'll probably come down to the popliteal segment again. You can see here we're making a little bit of progress. We have to go really slow with his blades. Now, you can hear it auditory, so we got through that area there that's tight probably. Keep going. Keep going. Pop it through here a little bit. Okay. You can hear it's again, this is another tight area of the lesion, so we're going to let it sit there. We're not going to let it, we're not going to push it through there.
Popliteal artery.
We're still washing our aspiration. We still got very good aspiration here. And we just that's what you want to avoid doing. So we're going to try to come through here, and we're actually bogging down too much. So what I'm going to do is I'm just going to come down through there with blades down again. Just make some more cuts through here. You can see even with the small blades, it's kind of difficult. So we're going to make one more pass for that.
This is another reason actually to go really slow, because you can get bogged down to the extent where you get caught up in the
I think
plaque.
that's probably what we're going to leave it at there. So we're going to now Rex it out again. Again, we're going to aspirate as we. So this will come back, and we're going to mag it up out here. So we're going to come back again, and we're going to remove the device, leaving the wire down there. And again, it's aspirating actively, and you can see it. It's all blood now, which is good. Keep on going there. And we're going to keep on coming around there until we're out. So we'll get you an angiogram here now. Please stop. So we'll get you an angiogram here so you can see exactly what we got going on there. We'll stay right about here because this is where all the disease was.
Tom McNamara with a question. Do you, what's your view
It's
of
looking a
the...
lot better.
That looks really nice.
And just so Amir and I can decide who's going to buy that scotch when I get over there, we're going to take a look at the foot to see if there's anything going down, if there's still blood going down there. I hope my pocketbook doesn't get a little bit lighter with this one. Let's see. So we'll mag it up so I can see it really good because I want Amir to be able to watch this. So we'll just... And it looks like we got some pretty good flow down there. Not all the way to the toes, but I'm going to go all the way to the toes because I know Amir will criticize me for that too. So we're going to do that again and do another injection here just to make sure we got something going all the way down there. So this is another digital. This is the level of the toes. You see, it's a little bit hypoplastic. I'm not getting good flow all the way down there, but I think we're okay there. So I want to give them they can have the mics back again.
Thank you so much, Tom. That was a great case.
Yep.
We'll see you back in a couple hours, and we're going to go ahead and move on to our next topic. Dr. Miguel Montero Becker, who will be talking about perfusion-guided CLI therapy.
Jaafer, before, as Miguel's making his way to the podium, what's your review and your use of nitroglycerin or other dilator and abciximab during a case like this where embolization is a concern?
No, that's a really good point. What I usually use is I use papaverin. It lasts a little bit longer. We start with 30 milligrams of papaverin IV, especially in something like this where you suspect distal embolization. If you get no reflow, I think adenosine is helpful. And if you have a high risk of no reflow, pre-treatment with adenosine is also very helpful. And I usually use heparin. I don't use Angiomax. What about you? What do you use, Tom?
I use the heparin, but I think ReoPro would be a good idea. Now, if 99% of the time you don't really need it, then maybe not. But it would seem like you can't do anything about the calcified fragments that might go downstream, but they'll attract, I believe, fibrin platelet aggregates and make it worse, and the ReoPro will preclude that, which I think is a good idea. On the other hand, it's not anywhere near as expensive as it used to be, but everybody's on top of us for spending money. So I was just wondering what people's thoughts were and experience.
We'll take a quick question just because we're running low on time, so go ahead.
What dose of ReoPro are you using? And do you ever use it before your atherectomy or only afterwards?
Yeah, it's the same bolus, 0.25 milligrams per kg, and I give it before I do any intervention. And once I cross the CTO, that's when I give it.
All right, Miguel.
Thank you. And first of all, I'd like to thank the organizers for having me here. It's pretty much the first time I've ever flown direct, which is crazy. From Tucson, you always have to go to some other place. But I guess there's a lot of snowbirds that escape the winter, and hopefully Amir will try to come to Tucson too soon. We're trying to get another partner. Amir, you should come. Perfusion-guided CLI therapy, ICGA, and MOXIE optimized interventions. I think this comes a lot from what the discussion up here was. Am I embolizing stuff and how is that helping us? And what are we ultimately trying to find? All these angiosomes to try to deal with critical limb ischemia and people with different patterns of disease, as we've seen people talk about today. And let me first say that we do have very suboptimal vascular non-invasive laboratories right now, which we deal with right now. This is, for example, a patient I got that the PCP actually did ABIs, and the ABI was absolutely normal. Well, yeah, it was normal because this patient had a normal anterior tibial artery with a palpable dorsalis pedis. And of course, he did an ABI and they told him it was 1. But this patient had no hindfoot perfusion. So the forefoot was normal, but the hindfoot was abnormal. And that's a term we've come in our practice to call the orphan heel syndrome, which you see mostly in advanced diabetic patients and CKD patients. Now, the problem is you need to change the game in a way that you could know how you're affecting topographically the foot in an intelligent way. One of the things we've tried to incorporate into our practice, and there's a couple of papers already out there from our practice into Journal of Vascular Surgery, is utilizing indocyanine green angiography, which basically for a long time has been used by plastic surgeons. They put this dye into the vein, they give it a little time to circulate, and it's ultimately going to come into the arterial phase. You do need a camera. There's CPT codes for this, so you get the reimbursement. And what you do is you actually focus on the area that topographically you want to know how well it's perfused. And so there's going to be pixeling of the area as the dye starts coming up. And this video will show you how a neuropathic ulcer is very well perfused in a foot. So there is no perfusion issues here. How do we know that? Well, we've created curves, and now we know what the ingress rate is and the egress rate is on a normal foot. And that's how it actually looks. You know, you darken the room, and then it lights up like a Christmas tree. It's very actually surreal. And once you create these curves, you could actually validate that to some of the normal vascular labs we have to say, well, this is the cutoff we need, and this is the perfusion we need. And now, of course, the next phase is going to be, well, what's the ingress rate you need to achieve perfection in wound healing? Like that classical, you know, we need 50 millimeters or more of mercury in the toe pressure, and then probably this guy will do good. Well, that's what we're trying to aim for. It's having a three-dimensional topographical way of know that what we're doing on the table is actually helping the specific area. Because also there's a lot of hype about angiosomes. Well, the thing is, we're all different, and our angiosomes are all different. So we actually need to have some objective data to try to guide our therapy. Let me give you an example. This is a patient that had an ongoing heel ulcer that failed with total contact casting. We could not get it to heal. And when we did the angiogram, we found that it was actually an orphan heel syndrome. So again, we had a normal anterior tibial, we had a speck of a tibioperoneal trunk lesion, but a normal peroneal artery. So of course, what did I think? Oh, I gotta go aggressively and open that posterior tibial that's occluded. Well, unfortunately, after some wiring and some flopping around, like the guys from Netherlands did against our team in Costa Rica, we were actually unable to recanalize the posterior tibial. But you know what? I treated the tibioperoneal trunk, and I was very sad. I was sad because this patient was not going to get ideal therapy. I wanted inline flow to that heel. But bear in mind, we had no way of knowing exactly what was going on. But when we did ICGA and we actually analyzed the curves, we found that just by opening that TP trunk, the collateral pathways that had already been instated was enough to actually 500% increase the perfusion of the heel, which led this patient to eventual healing. So it's pretty amazing to actually use ways. So maybe that one single vessel down to the foot that's angiographically beautiful isn't what you need, and you need something else. Now, something that excites me a whole lot is this other concept, because one of the things, and I'll be honest with the ICGA, the machine's huge. It's bigger than me. You have to roll it into the OR. You have to uncover the legs in the middle of the surgery. And of course, it takes time for the venous phase to come arterial, and so it just becomes unpractical. And so we were trying to come up with a way where we could do this actually on time, on the table, have a GPS for a surgeon, a cardiologist, a radiologist to know exactly where they're doing their work and if it's working. So in conjunction with a great team of scientists, we came up with the concept of using micro-oxygen sensing platforms to actually put subcutaneously and then measure this signal. So you actually inject it under the skin. It's made of very biocompatible materials. The material is called polyhema, which then has some other molecules that are actually oxygen sensing that are associated to the polyhema plastic, to the polyhema gel. And so you actually excite it, and then it captures oxygen in and around it. And it gives signals off that are actually taken up at that little sensor you see in the picture. So we did a small feasibility study, which we did in Costa Rica. And it was called the Si Se Puede, which in Spanish and English means yes, it can be done. And we just looked at 10 patients that we were bound to do CLI endovascular therapy. And we looked at them, and pretty much the same demographics we see across major studies. And this is just a couple of good case studies for you to see to limit time-wise. So this was a long popliteal occlusion, and that was the primitive initial phase of those sensors. As you see, they're actually taped to the foot. Now we have some really cool snap-on devices that were in development. But in any case, once you reconstitute distal flow, I'll walk you through this. These are the baseline oxygen, the oxygen levels that were sensed by these molecules at the skin level. And the lines, as you see, are representative of balloon angioplasty, as you're crossing lesions, opening, minimizing, deflating, opening, and then eventually the stent placement. And you see how after the initial first 2 or 3 balloon angioplasties, that curve starts going very in crescendo and saying basically significantly showing that there's a change in oxygen. Now, did we find changes that were actually recordable? Yeah. We found that actually every if you have 10 patients and the amount, we put about 3 sensors in each foot of the patient, and so we would prospectively see those, and then we would analyze how they would go up and down, and we saw that 96% of the records matched the expected changes in oxygen level that we had. Now, of course, you need to give this scientific validity, so the way we do this is that we expect changes that are bigger than at least 2 or more standard deviations initially, although some of these changes might be slow. We did that within the first minutes, and we found that 48% of those changes were actually 2+ standard deviations. So we think that there is a response that is time sensitive, that is acutely and in response to what you're revascularizing, and it could certainly allow a physician to take decisions on the table. Now, it would probably, being devil's advocate, it's probably going to be a better tool for doing tibial interventions because it has acute responsiveness to the changes that you have. Because in this case, for example, this was an old aorta bifem bypass graft that went down, and we were able to actually revascularize the external into the profunda, and that was it. This patient had no SFA, this patient had no pop, and then it trickled down into some collaterals down to the foot. But when we actually were open to, we actually revascularized that and actually stented all the way up and created inline flow to the profunda, at least that, we saved proximal perfusion. But what happens, at least, I don't know if there's some surgeons out there, when you do an endarterectomy of a patient that has no SFA outflow, usually the foot looks pale in the acute post-op. And as you give that patient some hours, some of those collateral pathways will create more diameter and will recruit, and then the foot turns warm. And this is what actually we saw. So by the end of the procedure, the oxygen level, look at after the balloon inflation and deflation, it was pretty stagnant, and I was a little sad. But then we actually kept the sensors. I said, guys, let's just roll them into the PACU, keep the sensors on, and let's see what happened. And amazingly enough, after about 3 hours, it picked up and it started going up and up and up. So the same thing happens. There's recruitment, and it's maybe not as time sensitive as you do more proximal disease, but certainly anything from the distal SFA to the POP to the tibial disease is going to have a 1-to-1 responsiveness. So I think that we're getting close to a time where seeking perfusion-guided therapy is probably smarter than that angiographic beauty and patting ourselves in the back because the foot looks bright and beautiful. Maybe it doesn't have to look bright and beautiful. Maybe you just do that one single speck of a tibioperoneal trunk lesion, and that will increase 500% your perfusion. And if you can be empowered with the knowledge on the table as an operator, imagine you could have it up there with an EKG, you would be in paradise, at least I would. So biocompatible oxygen sensors, although at an early stage, represent a potential operator GPS. Thank you guys for your attention, and I'll be around if there's any questions after this.
Thank you very much. I believe this technology is extremely helpful after the procedure is done. Not necessarily prior to that, but to do a procedure, then you evaluate and see if you have enough perfusion or not, or you need to do any further work. The next speaker.
Yeah, let me just say that quickly. One of the cool things also with these biocompatible sensors is we already have data up to 12 months out. So they actually will sense, and they have a half-life that decays, but you can adjust it mathematically. But you can get sensing up to 12 months. So if you think you could even have an iPhone app, you can even get it to a point where you can wand your iPhone across your foot and know what your oxygen levels are, and that could trigger a response back to your doctor that something may be failing. So it's just ideas for the future.
Well, we're going to have Dr. Zakir giving his talk. It's one of my favorite topics, the infrapopliteal anatomy and normal variation.
Okay, I'd like to thank the organizing group for the invitation. So we're going to review some basic anatomy. So the popliteal artery originates from the superficial femoral artery, the SFA, at the level of the adductor canal. It courses inferior to the femur, crossing the knee joint. Here it undergoes a short descent and bifurcation into the anterior tibial artery laterally, and the continuation of the tibial peroneal trunk. So this is a little cartoon over here showing that the popliteal artery originating in the adductor canal, crossing inferior to the femur, and branching off into the anterior tibial artery. You see the TP trunk, the peroneal artery, and the posterior tibial artery. This is an angiogram reviewing the same findings over here. We have our popliteal artery. We have some branches over here, the geniculate branches. And then over here we have our anterior tibial artery, our TP trunk, peroneal, and posterior tibial artery. As mentioned, the TP trunk bifurcates into the peroneal and posterior tibial arteries. The AT artery courses along the anterolateral aspect of the leg, parallel to the fibula, where it crosses the ankle and forms the dorsalis pedis artery. The PT artery courses in the medial posterior compartment, crosses the ankle and the calcaneus, and forms the medial and lateral plantar branches. These branches join the dorsalis pedis artery, forming the plantar arch. The peroneal artery flows to the ankle and stops. When you have severe pathology of the AT and PT, it forms important collateral pathways. So this, again, it's a little cartoon going, here's the posterior view and showing the bony landmarks. And you see the posterior tibial artery coming down, and you see it branching into the medial and lateral plantar branches over here. And you see the anterior tibial artery over here. As it goes down, it forms a dorsal pedis artery. And this is an angiogram showing similar findings over here with the posterior tibial artery. And you see here the lateral and medial plantar branches, which then form the TP trunk. You have the anterior tibial artery, dorsal pedis artery. This is just another cartoon just showing the arch a little bit more clearer, the lateral and medial plantar branches. And you see the nice plantar arch over here. And over here you see the anterior tibial artery forming the dorsal pedis, and then the rest of the arch. So now we'll talk more about the variants. So infrapopliteal arteries display a wide range of anatomic variations in contrast to the iliac and femoral popliteal arteries. Underdiagnosis of these variants may lead to less than optimal outcomes and potential complications. Recent angiographic and cadaveric studies suggest that the incidence ranges from 7.8 to 10.8%. We know that, what are the clinical implications? We know that infrapopliteal artery disease is predominant in critical limb ischemia, with chronic total occlusions as well as diffuse stenosis being the predominant findings. Understanding the predicted course can be challenging. Furthermore, a lack of awareness of infrapopliteal variants can result in a missed endovascular treatment opportunity, failed intervention, and potential for complications, including perforations. So Kim and al. Reported a practical triad of classification of anatomical variation in the branching patterns of the popliteal artery based on the angiographic appearance, which itself is a modification of the Lippert and Pabst classification. So the normal level of so type 1 is a normal level of popliteal artery branching, and the usual pattern that we see is found in 89.2 to 92%. A trifurcation is seen in 1.5 to 3.2%, and the anterior tibial perineal trunk 0.1 to 1.2%. So this cartoon goes over the type 1 patterns. So type 1 is normal, as we saw before. Type 2 is your, type 1B, sorry, is your trifurcation. You see all the branches coming off at the same point, the AT, perineal, and PT. And then the type 1C, you have the perineal artery coming off the anterior tibial artery. So these are your type 1 variations. So type 2, there's a high division of the popliteal artery branching. So that's an anterior tibial 1.2 to 5%, posterior tibial artery 0.4 to 2.5%, and the perineal 0 to 0.2%. So this cartoon reviews that. So we see a high takeoff of the AT. This is a little variation where the course is a little bit, varies a little bit. So that's a type 2 A2. Type 2B, you see a high takeoff of the PT, and the type 2C, you see a high takeoff of the perineal artery. Type 3 is a hypoplastic or aplastic branching with altered distal supply. So a hypoplastic, aplastic PT is seen 0.8 to 5.1%. Hypoplastic, aplastic AT is seen 0.1 to 1.7%. Hypoplastic, aplastic PT and AT is seen from 0.1 to 0.8%. So this cartoon again, reviews our findings over here with a hypoplastic PT, hypoplastic AT, and the type 3C is a combination of a hypoplastic AT and PT. So these are some angiograms. Dr. Lee was kind enough to share some of these. So over here we see a trifurcation. So we see the anterior tibial artery, the perineal, and posterior tibial artery all coming off at one site. Here we have a high takeoff of the anterior tibial artery, and these last two show high takeoffs of the posterior tibial artery. Here we have a perineal artery supplying the DP. This is a single vessel arch. And here we have the perineal artery supplying the plantar branches. So conclusions, as we treat more patients with critical limb ischemia, knowledge of the infrapopliteal anatomy and variants is vital to improve outcomes and potentially reduce complications. Thank you.
Thank you very much, Dr. Sikir. You know what I say? I say let's go ahead and take a break now. And we'll probably have to shorten our break just a little bit so we can catch up on time. So about 10, 15-minute break, get some coffee, and we'll start back here in about 10, 12 minutes. Thank you.